Unfortunately, Dr. Tevaskar, who is a great speaker, could not come. Otherwise, I was going to be a little relaxed because he was to cover almost 70% of the talk what I was to cover. So now I will have to cover everything because paradigm shift or comprehensive care, it's a change in the words. There is nothing else. Respected chairpersons, Dr. Manoj Bhai, Dr. Bhavsar, Madam Bhavsar, Parikh Sahib, Dr. Bide, Chaitanya Bhai, Mahadev Bhai, and Dr. Sant and Dr. Ayyar. Madhu Madam, Namaskar. Sir, Namaskar. Well, the topic is comprehensive and holistic management of type 2 DM, including reversal of diabetes. Next. Yeah. Pointer chair.
Pointer mani chalo LED chair.
I'm going to be little reverse. I'm going to talk first about the reversal of diabetes. Why? Because it is in line, it's in light. Everybody, hear and go everywhere. Somebody is saying, oh goodness, sir, and radios and TVs and whatnot, all interviews and everywhere it is some reversal of diabetes. And patients are unfortunately misled by a mass hysteria created by our colleagues only, and some fraudsters, and some organizations. Here it's a private, so I will not fear of uttering Patanjali, uttering their name. Those are the people, they say that, they can reverse the diabetes, they can cure the diabetes, The basic definition of a diabetes does not say it is a chronic progressive disease, where chronic progressive beta cell destruction is going on and on and on. At the most, apoptosis rate is reduced by liraglutide, and otherwise, none of the drugs, when you have glucotoxicity and you give a short-term insulin, particularly in a young man, I have 3 patients, those who had not reversal of diabetes, but of remission. The correct word is a remission of diabetes. I had 3 patients, all the 3 were young, first time detected diabetes, ketosis, blood sugar 500 plus, 38. Second was also in the same age group. But they agreed for insulin, educated. And this trial is already there by Darking also. It is mentioned in the textbook. They have done a huge study of around 3,000 patients. That acute intensive insulin management in the early part of diabetes mellitus. Remember my words. Early part of diabetes mellitus. મોદી સાહેબ હવે વાળ ઉગાડવાની ટ્રાય કરે તો ના ઉગે. Similarly, when your pancreas is almost gone, don't flog the tired horse. એ વખતે તમે એમ કહો, at that point of time you say that you will regenerate the pancreas. I don't. So when it is in the initial early part of the diabetes, when it is chronic, don't apply regression. Regression is also not possible. But reversal is a misnomer. The correct word is regression of diabetes. This is number 1. It's a myth. Number 2, as I mentioned, it is against the basics of the disease itself. Third, as you know, there are various molecules which, if given in early part of the disease, you can bring the HbA1c to a level. The reversal means what? You are free of the disease. That is called completely. Here it is not. It is and again the data is not sufficient. If the correct definition through Oxford, the reversal means you change it to at least 5 years without drugs, then you can say. But then basically when pancreas do not have beta cells, it is not going to be there. So reversal of diabetes, I'll come a little later, but this was, I thought, must clarify. All references and everything is through diabetes care 2024, rest as and when it is mentioned, please consider it. Well, this slide you must have seen empty number of times. Here the carry home message is only 2. When you start, previously we were under an impression that SGLT2 inhibitors, still, that if it is less than 30, you should not start. But you can start now up to 20. And you can go up to dialysis also. So that is one good point, one must remember. Here, first, when you see a person, please see that, how the patient, what is his profession, what is his income, what is his family support, is he ready to spend some 2,000 rupees or, 333 rupees tablet per day, semaglutide. So you have to consider his income status also. Where does he live? Is there any family support? So you make a patient a partner in the decision. Once the decision is made with consent, it goes a long way. You don't impose, make him a partner. So this is what it is. So review an agreement on management plan, providing ongoing support. Again, you must have an education, diabetes educator. We must have a diabetes clinic who repeatedly, either in groups, you can give some incentives also. कि अगर आपका HbA1c 7 से नीचे रहता है, 7 के पास आता है, 7 के आसपास 6.8, 6.9 से, तो हम 1 साल तक चार्ज नहीं लेंगे. It will be a great thing. So give them rewards. In providing ongoing support, monitoring, implement management plans. That is what I said. You have to create innovations. Dr. Buch is, innovative, and he can innovate so many things. Access key person characteristic, which I already said. That look, if he has associated diabetes with comorbidities, then you must think of everything before starting this. Consider specific factors which impact choice of treatment, utilize a shared decision making, and specific SMART goals. It should be achievable, it should be realistic, and it should be time limited. Here, this slide also you must have seen, but I have presented in a different way. More stringent HbA1c on the left hand side and less stringent on the higher side. Okay? So when you have risk potentially associated with hypoglycemia is very high, other drugs with along particularly sulfonylurea and insulin, the chances are high when it is given on the first slide. This is duration, longer the duration, to achieve the HbA1c to the less than 7%, it is going to be little difficult. Do you need diagnosis? Yes. Life expectancy when it is 85 and you have, my father is 99. He was diagnosed diabetes mellitus before a year. His HbA1c is 8.5%. Now what do I advise him? मैंने बोला सब खाओ मजे करो. Enjoy your life last days. So see whether he is going to live long. Important comorbidities, as we have already discussed, whether he has CKD, whether he has a stroke, whether he has associated, unfortunately, peripheral vascular disease or hypertension or anything, then the drugs would change. Establish vascular complications, individual needs and preferences. Here, you want insulin him to be taken, and he doesn't want. You want GLP-1 RA, then you have an option. You can go for SGLT2I. Individual needs and preferences and resources. Most important is पैसा बोलता है. पैसा बोलता है. Everything is money. It revolves around. And diabetes revolves around visceral obesity. Similarly, here also it revolves around money. This is again the same use of glucose lowering medications in the management of type 2. Here, important is, as I mentioned initially, particularly atherosclerotic cardiovascular disease, GLP-1 RA or SGLT2 with proven CVD benefits. Both of them have proven. If A1C is still above target, but with this and this, you can add either or, and glitazone with caution. Glitazone, one thing I must tell you, that in a patient of stroke, if HbA1c is not under control, if it is not coming under control, pioglitazone is a good molecule because it reduces the carotid intimal medial thickness. So the flow is going to be on higher. Yes, with caution. with caution. But otherwise, this is a good molecule, and it is almost insulin sensitizer like metformin. Recommendations about the blood pressure, that everybody knows that more than 130/80, it should be good. More than less than 150/90. Initial BP this. Start one agent, start two agents. These are all everything. But here, most important is you can start with any, whether he has complication or whether he has no complications. You can start with ACE inhibitor or ARB. You can with this or this, and calcium channel blocker. Remember, amlodipine causes almost 1/3 of the patients of amlodipine, they have peripheral edema. So is about cilnidipine also. Cilnidipine also causes peripheral edema, but that does not deprive him of the benefit which the molecule is enjoying over amlodipine. Cilnidipine is a poor antihypertensive drug, as I understand, as compared to amlodipine, but it reduces the intraglomerular pressure as well. So a patient of CKD, go for cilnidipine. SSBP control, continue therapy and everything what I have discussed. And this is the example what ideally one should do like this. Again, the drugs which are clinician's preference, always make a patient a partner in any of the decisions what you take. Whether you like GLP-1 RA or whether you take SGLT2 inhibitor, this is what it is important. Holistic approach for improving outcomes in people with diabetes and chronic kidney disease. This is important. Most important is lifestyle, physical activity, healthy diet, physical activity, reduction in the protein. How much protein should be reduced? We usually take 1 gram per kg, okay? In a patient of chronic kidney disease, not 0.5, 0.8 gram per kg. But if you reduce to 0.5, muscle wasting will be there. But there will be a good advantage because the end product and creatinine will be slowly progressive. That is one advantage. But here it is. So first line therapy with kidney disease, SGLT2, if GFR is more than 30, add metformin. Here SGLT2 inhibitor, as I mentioned, it was previously it was 30, now it is 20. RAS inhibitors, if it is required for hypertension, and moderate or high intensity statin. Here I talked upstairs. 46% of the LDL cholesterol is reduced, and if triglyceride, if it is more than 150, you add fenofibrate. But a forgotten molecule is ezetimibe. Why? I don't know. It is said to be a poor statin reduces LDL. It is the reason that it has gone into the backdrop. But one good advantage, before few days, I read a study where when it was used in elderly patients' ways, this improves the Alzheimer's disease also. This is one thing what one must consider about ezetimibe. Antiplatelet agent, moderate GLP-1 RA if needed, non-steroidal MRA, dihydropyridine that I already have discussed, antiplatelet agent. You can use one if required two, depending upon the clinical condition. Here also ezetimibe, they have mentioned, and PCSK9 inhibitor or ecospet ethyl. And these are for all patients, moderately or high statin, 40 milligram or 20 milligram of rosuvastatin, and right up to atorvastatin 40 to 80 milligram. Simplification of insulin therapy, it itself is a topic. Everybody knows good thing about insulin. See that don't be over enthusiastic. Don't be very, he is fasting, तो सर 110 से नीचे होना ही चाहिए. अरे भैया 110 से नीचे नहीं हुआ और सुबह में 90 हो गया, 80 हो गया, and not necessary that all patients will have complaints at 72 only. The definition of hypoglycemia is 72 mg/%. But some patients, they perceive the symptoms at 90 mg/%. Then, so please consider their symptoms also. Insulin is a big chapter, but here for elderly men, again, there is one change. Start basal insulin not in the evening hours, in the morning hours. Basal insulin. Okay? Here, new onset diabetes with overweight, with obesity, with clinical suspicion of diabetes initial. Here, A1C is more than 8, less than 8.5, more than 8.5. You must start insulin immediately. New onset, which I said, my 3 patients, they had a remission for almost 3.5 years, but ultimately they did not go into that. ACE, this is like a difference between MD practicing cardiology, diabetes, and real endocrinologist practicing diabetes. There is a difference. They are little more stringent. They are little more aggressive, more evidence-based, that's what they claim. ADA combines both of them. But this is what it is. So ACE has its own principles for the management. They are practically same: lifestyle, optimal weight, choice of HbA1c should be less than 6.5. You see, here there was 7. ADA 7, here 6.5. All targets A1C, GMI, TR, TBF, BG, PP2, everything has to be on the target. Not अगर PP2 200 हो गया 180 हो गया नहीं चलेगा. 140 145 ही चाहिए. Individuals get to goal as soon as possible, less than 3 months. Here, yes, this is important. Why? Then that our principle or talk of remission will be achieved early. And patient will have a long-lasting benefit. Complications-centric model care of persons, here it is very important. If obesity is less than, here for a patient of obesity, without doubt, start with SGLT2 inhibitor with metformin. Goes. It will, some people they have, I have seen some patients they melt like ice. They lose almost 5 to 10 kg, you don't know. The books recommend up to 4 kg or 5 kg. But some people they melt like ice. So with this, assess the stage, implement the plan. Stage 1, stage 2 through nutrition, physical activity, sleep. Dr. Madhevai said, last just few minutes back, a good thing about sleep. Eat well, exercise well, sleep well also. At least 7 hours of few minutes. Sleep well, because I think for 15 minutes are spared, so that's a blessing. So sleep at least 7 hours. You, once in a lifetime, at least if you get a time, please see that you hear Shashank Joshi's lecture. His always concluding remarks will be like this, what Madhevai said. Eat well, exercise well, but sleep well also. मनोज भाई रात का कॉल थोड़ा कम करो. Pre-diabetes algorithm practically same, 5.7 to 6.4. Start with metformin, but here again, one of the biggest study is DPP, Diabetes Prevention Program of USA. It showed that everybody is a pill. Society is a pill society. साहब exercise बगैर कसो થઈ આવ્યું છે. Now, if you see the here DPP study results, there was a 58% reduction with lifestyle modification, both nutrition and exercise, while there was a 21% reduction with metformin. So there is a remarkable difference of DPP. Similarly, Finnish study also proves the same thing, what I am talking about the DPP. Finnish is a good study. Pre-diabetes algorithm, overweight, obesity, 6, nothing. Metformin, glitazone, or carbos. Yes. Pioglitazone, I have been using very profusely and frequently in pre-diabetics. Why? It reduces HbA1c by 76%. Not a single molecule will reduce HbA1c by 76%. So glitazone in pre-diabetes is a good molecule because usually it happens in young people. So don't worry about the congestive cardiac failure, weight, edema हो जाएगा ये हो. अरे छोड़, आप जिंदा तो हो ना, फिर क्यों चिंता करते? Here, atherosclerotic cardiovascular disease, SS, lipid panel, pre-diabetes or type 2 risk factors. Here all they are. First see what they are. Here this is low HDL. There is no way to improve HDL, low HDL. Only way to improve is exercise. And if you are not taking alcohol, fine. But if you are taking alcohol, not stop. And third, right now, ADA has also recommended coffee. Coffee, four cups of coffee, four glass of coffee, glass or whatever they say, four cups of coffee per day. And if you remember a few days back, Dr. Sarins, one of the best gastroenterologists of the country, he said that his interview was taken like this, and he said, कि सर आपका कॉफी के बारे में क्या कहना है? And Dr. Sarin said कि सर अभी आपने प्रूव तो कर दिया कि कार्डियोवास्कुलर में भी बेनिफिट है, पर हमारे में भी बेनिफिट में है, NFLD में भी it is very useful. So if you are switching over from चाय to coffee, चाय पे चर्चा नहीं, कॉफी पे चर्चा. So coffee is good. Pre-diabetes risk factors, I don't think we must, everybody knows about the discussion which statin to be used. Initial statin that everybody knows. Medication, risk reduction, first line. Here, drug about the ACE inhibitor or ARB, okay? If it is then dual therapy, add sitagliptin, combined either alpha or beta blocker. Beta blocker is now almost our, algorithm, but AAC has not said no. AAC has not said no that you should not use. It is unfortunately a bad ship like atenolol that caused the havoc, and that is the problem. I have been switching my all patients of atenolol for last 20 years. Since the land of, this Scandinavian countries studies, they came and they say that with this atenolol, it increases the chances of stroke, 11% rise in the incidence of stroke. Since then, I have been changing. So combine this and additional antihypertensive. Here, one of them is a clonidine. In your OPD, suppose all of a sudden a patient of 220 by 120 patient has come and he has mild headache. He has come walking, no vomiting, nothing, no convulsions. Then what do we do? He doesn't, he is ready for hospitalization. Give 2 tablets of clonidine, 0.1 milligram, 100 microgram. Maximum dose is 1000 microgram. So I am sure within 1 hour his blood pressure will drop. But sublingual depin is out. Complications of centric glycemic control. Yes, this is very important. If target is not achieved in 3 months, anything can happen, and that is what we want to avoid. Here, atherosclerotic cardiovascular disease, the drug of choice is GLP-1 RA. Here in heart failure, without doubt, SGLT2 inhibitor, because everybody would love a pill rather than an injection, plus cost. Stroke, I mentioned about glitazone or GLP-1 RA. Kidney disease, GLP-1 RA or SGLT2 inhibitor. Where is Kamaldeep? Sir, do I continue for? His permission is required, he is the boss. Glucocentric algorithm, yes, now that concept is out. We are concerned about glucocentric. Instead of that, we maintain HbA1c and complications related treatment management. And now, we are concerned about the associated comorbid conditions related molecule. अगर मोटा पेशेंट आ गया 120 kg पेशेंट and he is obese, he is first time detected to this and he is ready to spend, then what? Semaglutide, 333 rupees per tablet, it's okay for him. So this particular molecule, and remember the study showed that 20% reduction in the weight loss. And if you see the share market of Novo Nordisk, in last year it rose by 1200%. Why? Because of one molecule. And it was sold in the grey market at a hefty price. The production was tripled by the company. Then also they could not, still they are in a waiting list. But all said and done, a good drug. I think Sun Pharma has just put a paper for his trial, and if Modi Sahab was talking like that, so I am also saying like that. अगर सन का शेयर नहीं खरीदा है तो खरीद लेना. अगर if that drug comes to India, we will be the winner in the India, whole world. Concerns about this, avoid sulfonylurea, glucose, particularly this overweight, sulfonylurea or glitazones. Here, hypoglycemia, sulfonylurea, glinites. And again, 7 to 8%. Here, individual glycemic target should be less than 6.5, but we are little liberal. As I mentioned, my father is 99, and I have allowed him to 8.5%. If goal is not achieved, continue to algorithm for adding insulin. So he has put insulin last, that is a good thing. This is a good slide, but weight loss medications, these are all, semaglutide is number 1. You see here, 15 to 18% reduction. Weekly subcutaneous injection and 2.4 milligram per week. And the lowest reduction is orlistat. Orlistat, the cost of the tablet is, and per year, is more than 18,000. And you are reducing 4% weight. It is useless. Pre-diabetes, yes, pre-diabetes. We also have good number of pre-diabetes. Probably everyone sitting in the whole prestigious distinguished guest could be pre-diabetic. Out of 3, at least 1. The highest number of pre-diabetics are there in North America, and Europeans, they are, one must say about the Europeans, they are selfish, but they are selfish about their health also. If you see Netherlands, if you see Norway, if you see Finland, the happiest country in the world is Finland. Happiest index, if you see this a few days back. And yesterday's Sunday's paper, there was an article from, substract from Lancet Journal was there. This is concern for us, for Indians, that inactivity in the males is rising day by day. Before 3 years, it was 40%. Now it is 50% in males. And females, it was 30%. Now almost it is 60%, doubled. So physical inactivity, probably, it leads to other complications. Lifestyle intervention, which I already mentioned, DPP, reversal of diabetes, I have discussed. Thank you.